Thank you, Ariska. So the take-home points we're going to just leave up on the board. Some questions have been percolating in. Please feel free to either send me those questions, which I'll ask our panel when we begin. But I'm going to now invite Heather to come up and say a few words about how this, as a patient, has influenced her thinking on this topic. I think it's quite informative.
Good morning. Thank you for having me speak today. For the past 30 years, I've lived with ARVC. 5 years ago, I tested positive for the PKP2 gene mutation. Genetic testing was helpful because it revealed the genetic cause of my heart disease. It was also supposed to be the impetus of cardiac and genetic testing for my family members. In actuality, motivating my family members to get evaluated became one of the most challenging and frustrating parts of living with my disease. As everyone in this room well knows, the ostrich effect of burying one's head in the sand when they hear bad news is alive and well. Even after 25 years, my family was in deep denial. I can't begin to tell you the frustration of watching my then 12-year-old niece compete in swimming races while I sat poolside with my sister as she tossed up every excuse in the book to evade cardiac testing. And when my brother decided to have a child on his own, in vitro testing was available to him, but he refused to hear about it. In 2014, I was diagnosed with heart failure as my ARVC progressed. Even then, my siblings did not take action to get themselves or their children evaluated. Luckily, the turning point was when my sister experienced a sudden cardiac arrhythmia event in front of me. Lucky because I recognized the warning signs and got her help, and lucky because it brought the whole situation to a head. My sister and brother finally got tested, and both are negative for the PKP2 gene mutation. But given my sister's symptoms, it's probable that she and I might share another gene mutation that has not yet been discovered. If there's one take-home, it is that genetic counselors must do more to psychologically support the patient who has the burden of encouraging their family members to seek medical assessment and genetic testing. Back in 2013, I got a one-page letter from the genetic counselor telling me of my PKP2 gene mutation, but nothing by way of documents or sample letters to pass on to my family members explaining ARVC, the need of getting medically evaluated, or the risk of sudden cardiac death to them and their children if it went undetected. There was no other follow-up. I felt alone. With the growth of commercial genetic testing such as 23andMe, genetic counselors are at a risk of losing their status and market share. You cannot let advertising agencies and ill-trained call center reps do your job of interpreting test results and counseling patients in distress. This means fighting for more genetic counselor positions in clinics across the country, using new technology such as Skype to communicate with remote patients, and being more proactive with follow-up to newly diagnosed patients. And finally, you must look for ways to reduce the burden to the patients who have to inform their family members. They are already struggling with their own diagnosis and disease management. Thank you.
Heather, please welcome you. Have a seat. There may be some questions because I think you truly bring a really wonderful perspective here. Very useful. So I'm going to just sort of take off and again, we'll leave some of these summary points up here. The first question that came in is there a role for genetic risk score assessment in secondary prevention? So that means now you've had an event, and genetic risk score assessment. Who wants to tackle that one? Mel?
No, sorry, I'm not sure. I think that's more of a cardiology, like a cardiologist, for the cardiologist, I think. Sorry, I can't answer that question very well.
Seema?
So I think there's been a recent couple of papers talking about polygenic risk scores for coronary artery disease, et cetera. So we can see that coming in the clinic, I think, as more robust genetic risk scores become available. But currently, I don't think there are risk scores for disease. And as an example, even within cardiomyopathy patients, which is monogenic, we are seeing that if you have 2 mutations, you are more likely to have a severe phenotype that may in future be used for risk stratification. We're trying to incorporate it into a sudden cardiac death risk prediction model. But right now, I don't think those scores are clinically available.
So a related question, I think you touched on it. Is there a role for genetic testing if I have an idiopathic DCM?
Yeah, that I can speak to a little bit better. My role is primarily in the monogenic inherited heart diseases. Idiopathic DCM is more likely to be related to non-genetic factors, truly. It's not that we wouldn't necessarily find monogenic condition or monogenic disease in a dilated cardiomyopathy, but we're more likely, much more likely to find those in the context of unusual clinical diagnosis, sort of early age of onset, multiple family members affected. Your 60-year-old person with an idiopathic dilated cardiomyopathy may not be the best person to initiate genetic testing on. However, there's no hard and fast rule to that, I would say. So overall, you're looking for unusual presentation of common disease to be considered for genetic testing in this particular condition. And I don't know if you would sort of agree.
Yeah, I would say that although the yield is lower, so 10 to 15% in DCM, we still offer it to families and let families decide if they want to go forward.
But as the price of full genome sequencing drops, and as more and more genetic testing becomes available commercially at lower and lower cost, you're going to have people who are going to be presenting with this data. So this is going to be an evolving field, and I think a really relevant question. I want Josh to address this because he made the point well taken. If genetic testing is dynamic, how often should it be repeated? So let's say, yes.
What we usually tell
Someone
our
is
patients,
like there's nothing found, but
what I usually tell patients who come to me and either have a negative genetic test result or an inconclusive genetic test result is that they should recontact me every couple of years or so. On average, within a couple of years, we do tend to discover new genes and the panels expand. I mean, they may call me in a couple of years and absolutely nothing has changed, but at least they've reached out to me and I may have something to tell them at that point. How often should genetic testing be repeated? That really depends on how the medical evidence has progressed in the intervening time.
One thing just to add to that is not only the actually repeating the genetic test, but as Josh mentioned as well, just the reinterpretation of the result. So it doesn't necessarily mean that the test actually has to be redone or rerun, but that the result be looked at again with the new available evidence that may have come out in the last, I would say probably 2 years might be appropriate if there's a variant of unknown significance to have it reassessed.
And Josh, you also made the point that not having something identified doesn't mean that there isn't a genetic basis for it. So there's a question related to that. Are there pathologies that you can rule out with confidence with a genetic testing? For example, long QT. Is the answer no?
The answer is no. Yeah, even with long QT syndrome, which has a fairly pretty good detection rate of about 75% of people with congenital long QT will have a mutation in one of the 3 most common genes. We see enough patients in our clinical practices with, again, clinically diagnosed long QT syndrome that don't have mutations in those genes. So I would say there are no inherited heart diseases that can be effectively ruled out with genetic testing.
With our current state of knowledge.
Absolutely.
Yeah.
Probably the only exceptions to that would be a couple of rare phenocopies like Fabry disease and Friedreich ataxia. But even then, I would never say it's completely ruled out if the testing is negative.
Any additional questions from the audience?
This is an important question,
Yeah.
actually.
Go ahead.
Oh, sorry.
Yeah, go ahead.
I think maybe Josh wants to
I think
answer
just
it.
came in, yeah.
Yeah, so in the question was in the 16-year-old boy who presented, had he died before he could have been evaluated, would genetic testing have been done? And if not, what would the approach have been for the surviving first-degree relatives, where in the index case, you don't really know what the genetic cause is? So there are 2 important questions here. Do you want to address?
That's a great question. Molecular autopsy has become more common in the last few years. I'm not sure what's happening in other geographical areas, but in Ontario, patients with sudden cardiac death that are becoming coroner's cases. they are eligible for genetic testing through funding specifically through the coroner's office, and they are performing gene panels and then returning the results to the family, who are then referred to genetics. Again, I don't know what the situation is outside of Ontario, so this is very geographical specific. Even in cases where coroners are not arranging the genetic testing themselves, would definitely encourage you to refer families to genetics in these situations. And as a genetic counselor, what we often do is try to obtain any kind of tissues or stored blood samples that might have existed on the deceased patient and try to arrange genetic testing on those samples. And this is actually fairly frequent in our practice, and we do often identify pathogenic gene variants in deceased individuals and then offer cascade testing to family members.
And I think the second question, that if you really don't have access to the genetic test, it's not possible to get it on the deceased individual, then I think it's appropriate to clinically follow the rest of the family members, and if someone shows a phenotype in that event, offer them genetic testing.
Any final questions, comments? Heather, anything from you? Questions from you? Well, with that, thank you all very much for attending this workshop, and please fill out your evaluations, as it'll help inform whether we do a similar updated genetics workshop next year. Thanks very much.